Neurology. Very good morning to all the attendees. And today's session will be taken by Dr. Ajay, who is the presently senior consultant at Chowdhury Hospital and Research Center, Udaipur. He was previously senior consultant neurologist at R&T Medical College, Udaipur. He did his post-graduation in neurology from my alma mater, PGI Chandigarh. He was awarded Fellow of the Royal College of Physicians, Glasgow in 2020 and Fellow of the Royal College of Physicians, Edinburgh in 2021. He had 20 publications in national and international peer-reviewed journals. He is the first person to identify and report apogenotropic variant of posterior semicircular canal BPPV from India in 2020, and he has contributed 3 chapters. He is a very active member in PGI Alumni WhatsApp and quite interacting and presents post cases in PGI WhatsApp. With this introduction, I over to Ajay.
Thank you, sir. Thank you so much for your kind words and encouraging words, which mean a lot for me, for a stalwart like you. I'm sharing my screen. The topic allotted to me was approach to positional vertigo, and this is the exact topic, the approach to benign paroxysmal positional vertigo. We'll call it BPPV from now onwards, diagnosis and management by physical therapy and repositioning maneuvers. Benign paroxysmal positional vertigo is the most frequent cause of vertigo worldwide. It is characterized by severe rotational vertigo triggered by changes in the position of head relative to gravity. Typical situations are lying supine, getting up from supine, bending forward, say for tie the shoelaces, taking lateral recumbent positions, extending the cervical spine to place an object on high shelf, or in the situations as is depicted in this picture. Almost all these features are almost uniformly present in all variants of BPPV. However, the autonomic symptoms like perspiration, nausea, vomiting, and are more common in the horizontal canal BPPV. This is a mechanical disorder of membranous labyrinth which is caused by vestibular lithiasis, which exists in 2 forms. Canalolithiasis, in which the degenerative otoconal debris detaches from the utricular matrix and inappropriately enters one of the 3 semicircular canals, namely posterior, horizontal, and anterior in that order of frequency. The other one is cupulolithiasis, in which the otoconal debris becomes inappropriately adherent to the cupula, making it heavy and gravity sensitive. The cupulolithiasis also exists in 2 forms, with the otoconia either getting attached to the canal or to the utricular side of the cupula, and this cupulolithiasis is best seen in horizontal canal BPPV, and a model of the horizontal semicircular canal is in this slide. As we see that this is the utricle, this is the dilated portion of the semicircular canal which houses the cupula. This is the slit-like picture here, and this makes this impervious to any flow of otoconia out of the utricle, where they are normally embedded in the utricular matrix. So the cupulolithiasis can occur either on the canal side, as we see in this 2B, or on the utricular side, which is seen on the diagram 2C. So this is a horizontal semicircular canal. This is the dilated portion. This is the ampulla housing the cupula, and this is the anterior arm of the horizontal semicircular canal, and this is the posterior arm of the horizontal semicircular canal. The important point to note here at this time is that the most common variant of the horizontal semicircular canal BPPV is posterior non-ampullary arm canalolithiasis, which causes a geotropic nystagmus during the supine roll test, while the cupulolithiasis either on the utricular side or on the canal side, and the anterior arm canalolithiasis of the horizontal semicircular canal causes an apogeotropic nystagmus. These terms we will be coming on again and again as we go through the horizontal canal BPPV variants, geotropic and apogeotropic, and I have dedicated 2 slides in explaining them what are they mean. So why does the vertigo occurs? Normally our semicircular canals work in York pairs. That is, if the right-sided anterior semicircular canal depolarizes, then the left-sided posterior semicircular canals hyperpolarizes. So normally no vertigo is perceived during active movements which we make in our day-to-day daily life. However, why does vertigo occurs in BPPV? There is inappropriate stimulation of canal after cessation of head motion, and this leads to transient sudden asymmetry due to free-floating otoconia in the canal. So BPPV is a stimulatory type of vertigo in which the otoconial debris, they keep on floating after the head has ceased, and this I have explained in the next slide. Otoconia get detached from the hair cells in the utricle, and they inappropriately enter one of the 3 semicircular canals, the posterior semicircular canal being the most common, then horizontal, and then anterior semicircular canal is least common. In BPPV, after cessation of head motion, the free-floating otoconial clots within the semicircular canal keep on dragging the endolimbs within the and thus volleys of unsolicited vestibulo-ocular reflex are generated because of inappropriate stimulation of canal after cessation of head motion, and this results in right-left asymmetry of the York semicircular canal pairs. The Dix-Hallpike maneuver for the posterior and anterior semicircular canal and supine roll test for the horizontal semicircular canal lateralizes the site and localizes the affected canal by generating the oculomotor patterns that we know as positional nystagmus, and they need to be carefully observed. So the Dix-Hallpike test in vertical canals in posterior semicircular canal BPPV, it elicits upbeating and torsional nystagmus. In anterior semicircular canal, the positional nystagmus is downbeating and torsion is often little or absent. The supine roll test, which evaluates the horizontal semicircular canal in canalolithiasis, causes horizontal and geotropic nystagmus, while in cupulolithiasis it causes apogeotropic and horizontal nystagmus. One exception is anterior arm canalolithiasis of the horizontal semicircular canal, which behaves like the cupulolithiasis, eliciting an apogeotropic nystagmus during the supine roll test. So this is a diagram which is showing the relative prevalence of the variants of the BPPV. The posterior semicircular canal around 85 to 90%, 10% is around horizontal canal BPPV, and less than 1% cases are because of anterior semicircular canal BPPV. The diagram which I have elicited here shows the membranous labyrinth of this female, the left membranous labyrinth, and the A here represents the ampullary dilatation which houses the cupula. So this is an impervious part of the semicircular canal, and though no otoconial clot can enter from this ampullary end of the canal. So from where these otoconia come, they become detached from the utricular matrix, which is degenerative, and they enter one of the semicircular canals through its non-ampullary route, that is the posterior arm of the horizontal semicircular canal here, which I am showing in this arrow. And this is a portion where the non-ampullary ends of the anterior and posterior semicircular canal join to form crus commune. So this crus commune is in communication with utricle. Any otoconal debris which detaches from the utricle, it enters the cross commune, and because the posterior semicircular canal is oriented such that its lowermost portion is its ampullary end, so any otoconal debris which enters this portion easily gets entrapped near its ampullary end. So this variant of posterior semicircular canal BPPV is most prevalent for this reason. The same is true on these lines. We can explain why the anterior semicircular canal BPPV is least prevalent. This non-ampullary portion of the anterior semicircular canal is almost vertical. So in the upright position, it is almost impossible for any degenerative otoconal debris to enter this canal and get trapped near its ampullary end. So it is the least common variant of the BPPV. The horizontal semicircular canal is slanting around 30 degrees backwards from anterior to the posterior side, and any otoconal debris which enters its non-ampullary end has a high liability to get repositioned back as the patient lies supine and takes the lateral recumbent position. So when patient lies supine, the horizontal canal becomes vertical in orientation, and any otoconal debris which has entered into it has chance to getting it repositioned back. So the spontaneous remissions in the horizontal semicircular canal BPPV, they are most frequent. This is the only variant of the horizontal of the BPPV where the spontaneous remissions are most common, and almost in one of the studies they have shown that around most of the patients, they spontaneously resolve if it is a canalolithiasis in a period of 4 to 6 weeks. So with this anatomy in background, if we know the spatial orientation of these canals, we will know how the otoconal debris which is there in the posterior canal or in the horizontal canal will be repositioned back, because what we need to do is to bring this non-ampullary portion of the canal into the most gravity dependent position during the therapeutic repositioning maneuvers as far as the canalolithiasis is concerned. So this is one slide I have dedicated to the Ewald's law, because they form the basis of the localization, lateralization, as well as the generated patterns of the positional nystagmus. The great Julius Ewald, in his experiments in pigeons, framed the laws that bear his name. In 1892, he cannulated each of the 3 semicircular canals and applied positive and negative pressures to observe the intensity and direction of the generated nystagmus. 2 main outcomes of his experiments were: number 1, the generated nystagmus is always directed parallel to the plane of the stimulated canal. That is the Ewald's first law. So this applies to all positional tests when we are making a positional nystagmus during the Dix-Hallpike positioning or supine roll test. We are orienting the canal in such a way that there is movement of the otoconal debris, and this creates this generates the nystagmus. The second is that, this is most important, the generated nystagmus is stronger when the endolymph moves towards the ampulla. That is ampulopetal in case of the horizontal semicircular canals. This is the Ewald's second law. And away from the ampulla, that is ampulofugal in case of vertical semicircular canals, that is the posterior and anterior semicircular canals. This is the Ewald's third law. With this in background, this is a person having vertigo. I will not go in their histories. In the right Dix-Hallpike position, we see there is an upbeating nystagmus which is clearly torsional to his right side. So this is the most common variant. Upbeating nystagmus during Dix-Hallpike head hanging position. This is the right Dix-Hallpike positioning. The head was rotated 45 degrees to his right, and head was taken 20 degrees below the horizon at the end edge of the table, and it elicited an upbeating nystagmus which was torsional to the patient's right, and that is always occurs. The direction of torsion in case of vertical canals is towards the patient's involved side. So how this is generated, we need to know that from our knowledge of the Ewald's law. When the patient is taken to the right Dix-Hallpike position, see the right upper figure on this side. In the figure 2 here, we see that otoconal debris, which is in the posterior canals near its ampullary end, it moves ampulofugal. So ampulofugal movement is excitatory. So the excitatory impulses of the right posterior semicircular canal, they are to the ipsilateral right superior oblique and left inferior rectus. So in right Dix-Hallpike test, the excitatory impulses in the right posterior ampullary nerve results in primary co-contraction of right superior oblique and left inferior oblique. And this causes a slow phase VOR, which is downbeating and left torsional. The fast phase VOR, which is a refixation saccade and which we clinically appreciate as positional nystagmus, is therefore upbeating and right torsional. So this I have shown in this lower figure A and B. This is the superior oblique, this is the inferior rectus, and as patient is taken to the right Dix-Hallpike position, the excitatory impulses, they cause the downward movement, which is slow phase and which is left torsional from the patient's perspective. So the refixation saccade will be exactly opposite in its vector, that would be upbeating and right torsional. So this is how the nystagmus of posterior semicircular canal BPPV is generated. And for this, in one of the diagrams, we will see the excitatory and inhibitory projections of the semicircular canals. So when we do a Dix-Hallpike test, you don't need to have these Fresnel goggles. In fact, this is a patient who had, this video is around 10 years old. In the right Dix-Hallpike position, he elicited a nystagmus after latency. You can see it is upbeating. Just see the vessels. It is right torsional in this position. So he was in the correct position to complete a Apley maneuver. In fact, the Dix-Hallpike position, if it is maintained for 1 minute, it will constitute the position 1 of the Apley maneuver. So we maintained this position after seeing this pattern of nystagmus, which was upbeating and right torsional from the patient's perspective. Maintained this for 1 minute. After 1 minute, the head was inclined 90 degrees to his contralateral side, and this position was maintained for around 1 minute, completing the 1 Apley maneuver. So the third position is also there. We take their left lateral recumbent position, and this is for another 1 minute. And after 1 minute, the patient is taken to the upright sitting position, completing Apley maneuver. So there are 3 positions, first, second, and third, which we had seen in this video. And after completion of position 3, the patient is taken in the upright sitting position, completing the Apley maneuver. It is important to do a verifying positional test about 1 hour after the repositioning maneuver, whether it is Apley maneuver or any other maneuver, to look for disappearance of the positional nystagmus as well as vertigo, and as well as a phenomenon called canal switch that we will be seeing in our next patient. This is a 59-year-old lady who had come with 2 days history of vertigo on lying supine and on assuming either of the lateral recumbent positions. The Dix-Hallpike test in a lady who was very sensitive was performed by using a 4-inch thick pillow to give a 20-degree head hanging position. Left side it was negative. On right side, an upbeating nystagmus was observed, which was right torsional. She closed her eyes, but during the last part, you can see the upbeating, and it is a right torsion. So right posterior semicircular canal BPPV was diagnosed. So we started treating these patients with multiple Apley maneuvers. The usual practice in our center is to do 5 Apley maneuvers, 3 to 5 Apley maneuvers in one session of treatment. And every time we do a Apley maneuver, we see the step 1 of the position 1 of the Apley maneuver, which constitutes the Dix-Hallpike test, would tell you whether this patient has been repositioned or not. So when I was doing the Apley maneuver for the 3rd or 4th time, I saw an apogeotropic positional nystagmus of horizontal semicircular canal. So I repeated a supine roll test, which is shown here. Supine neutral position. This has to be capped for around half minute. If no nystagmus is seen, then lateral head roll to right as well as left is essential, because a secondary sign of localization, lateralization, which is called the LDN, will be observed sometimes. So on the right, you can see an apogeotropic nystagmus, the quick component of which is beating away from the patient's lowermost right ear. So if it is apogeotropic on right side, that is the lateral head roll to right, it has to be apogeotropic on lateral head roll to the left. In horizontal canal BPPV, the positional test, that is the supine roll test, has to be positive on either sides of lateral head roll, and the identical patterns of the nystagmus have to be observed to make a diagnosis. So if it is apogeotropic in lateral head roll to right, it has to be the same pattern seen on the left. So on the left again, the apogeotropic pattern you can see after some time. Now it has started. In the right eye, you see a nystagmus which is horizontal beating, the quick component of which is away from the lowermost left ear. So the side was not a problem because this patient had initial right-sided BPPV, posterior semicircular canal BPPV, and she had a canal switch as a result of the Apley maneuver, and she now had apogeotropic variant of horizontal semicircular canal BPPV caused by short anterior arm horizontal semicircular canalolithiasis of right side. So this patient was treated with Appiani maneuver after the canal switch. From the short sitting, she was taken to the ipsilateral, that is ipsilateral lateral recumbent position. This maneuver is from the paper by J.C. Appiani 2005. This position was maintained for around 1 minute, after which her head was inclined 45 degrees in the yaw axis, and the second position is maintained for around 2 minutes, after which she was uprighted to short sitting position, completing one Appiani maneuver. The usual practice in our center is to do 2 Appiani maneuvers for the apogeotropic variant of horizontal canal BPPV, suspected to be because of the short anterior arm canalolithiasis of the horizontal semicircular canal. So when this was done, again a positional test was taken up 1 hour later, and because she had horizontal canal BPPV at this time and we treated for horizontal canal by Appiani maneuver, supine roll test was done. To the right side, now you can see that she had again an upbeating nystagmus, you can see, and it is right torsional from her perspective. So she had a second canal switch from right posterior horizontal semicircular canal to the right posterior semicircular canal. Important thing to note here is that the supine roll test occasionally elicits an upbeating ipsitorsional nystagmus, which is characteristic of vertical canal BPPV due to posterior semicircular canal BPPV, and this is not uncommon. So we treated this patient again with the Apley maneuver. This time the Apley maneuver was done 3 times at an interval of 15 minutes with postural restrictions in between first and second and third Apley maneuvers. We use a 4-inch thick pillow. This was a sensitive patient. Rotate the head 45 degrees to the side of lateralization, taken to the head hanging position. This position is maintained for around 1 minute. after which the head is inclined 90 degrees to the contralateral non-involved side. At this time, she had a severe vertigo, and she, in fact, had severe nausea at this time, as you can see here. This is the position 2. It's maintained for around 1 minute, and subsequently, she was taken to the third position, that is left lateral recumbent. For another 1 minute. This method of treating with using a pillow as vantage point to give head hanging position is described in this article and is basically for self-treatment of PPPV by Simon versus Aple manuals. However, in patients who are very sensitive like this female, I always prefer to do it using this type of pillow, and I have successfully treated almost every person with this method, although recommended for the self-treatment by the patients. So after 1 minute in the position 3 of the apply, she was taken. I just rewind the video. This is important in showing this. As the patient is taken to the upright sitting position, she had a severe pulsion, you can see it. And sometimes it is so severe that patient has tendency to even fall forward or backward. So you have to hold the patient for some time after completing the third position of the Aple maneuver, and when they become stable, then you have to leave them. Otherwise, they might fall and injure themselves. So in this patient, a verifying supine roll test was taken 4 hours later. The supine roll test as well as the Dix-Hallpike test was done. In the left video, you see supine roll test, which was done only on the right side, and the supine roll test was done by lateral head roll to right. This is the supine neutral position, lateral head roll to right, as well as to the left. Now to the left. Patient did not elicit any positional nystagmus and she was vertigo free. All such patients who are treated with any form of repositioning maneuver, we do a verifying positional test at 1 hour and after 24 hours, and we weekly telephonically interview patients for recurrence of vertigo for at least 4 weeks. This is the protocol set by the international standards. So when we saw the literature, we saw that we did the right thing. It is in centers where more than one single Aple maneuver is performed in a single session of treatment, a delay of 10 to 15 minutes appears to be appropriate between successive maneuvers because a certain period of restraint in the vertical position after canaleth repositioning maneuver, that is Aple maneuver in this case, may prevent the immediate reflux of the otoconia back into the other canal. But this needs to be confirmed by the randomized trials. Our practice has changed after this patient because of double canal switch. This is another patient in whom right Dix-Hallpike test elicited a down-beating nystagmus in the right Dix-Hallpike position. And as the video proceeds, you will appreciate that the upper poles of the eyes are moving, are directed towards the patient's left ear. These are the video Frenzel goggles, which are known as the Mu Frenzels. So this nystagmus is downbeating and left torsional from the patient's perspective. Normally, when you see such pattern of the nystagmus, and provided that you have ruled out a central pathology, this would mean left anterior semicircular canal BPPV. This was a quite long nystagmus, lasted for full 1 minute. So we treated this patient with reverse Applet maneuver. That means the Applet maneuver for the left anterior semicircular canal BPPV to be started from the right side. So right-sided head hanging position, maintained here for around 1 minute. Position number 2, maintained for 1 minute. Position number 3, maintained for 1 minute. And subsequently she was uprighted to the short sitting on the examination table, completing 1 reverse Applet maneuver. We continued to do reverse Applet maneuver starting from the right side for 7 days, but this patient did not respond. On day 8, I was expecting that this would now respond to treatment. We could see an upbeating nystagmus, which is clearly the quick component is beating towards the upper pole of the eye, and it is clearly torsional to the patient's right. So at this moment, this is a right-sided posterior semicircular canal BPPV, the common variant, the most common variant which we see. So what happened to this patient? That we will discuss after one slide. At this time, we again treated this patient with Applet maneuver. For right posterior semicircular canal BPPV, it would be doing right Applet maneuver, the exact thing which we were doing for last 7 days. And which we did the same thing. We did 3 Applet maneuvers, and then we did a verifying supine roll test after 1 day. No positional nystagmus. No vertigo. Because the positional nystagmus initially was of 1 minute duration, we kept her head hanging for almost 1 minute to look for any latency, and there was no nystagmus. So when we searched the literature, we found the answer. Why this dilemma occurs? In the right Dix-Hallpike test, the ampulofugal cupular deflection of the left anterior semicircular canal that we were suspecting left anterior ampullary nerve excitation and ampulopetal cupular deflection of right posterior semicircular canal, that is right posterior ampullary nerve inhibition, that what it really was, results in co-contraction of left superior rectus and right inferior oblique. This causes a slow phase VOR, which is upbeating and right torsional in either case. The fast phase VOR, which is a refixation saccade and is clinically appreciable as positional nystagmus, is therefore downbeating and left torsional, whether it is left anterior semicircular canal BPPV or right apogeotropic variant of the posterior semicircular canal BPPV due to canalolithiasis in the non-ampullary portion. Just focus on the left diagram. The right panel here shows the otoconal debris in the non-ampullary portion of the posterior canal near the cross commune. So as the patient is taken to the Dix Hallpike position, there is movement of the otoconal debris, which is ampulopetal. The ampulopetal pupillar deflection is inhibitory in case of vertical canals, and this is a vertical canal, posterior semicircular canal, and the inhibitory projections of the right posterior semicircular canal are to the right inferior oblique, as you see in this right figure, and left superior rectus, that is ipsilateral inferior oblique and contralateral superior rectus. So right posterior ampullary nerve causes inhibition, causes a slow component which is upbeating and right torsional. Now just concentrate on the left figure, middle panel. This is the anterior canal and this is the otoconal debris which is in the which is near the ampulla of the anterior semicircular canal. As the patient is taken to the right Dix Hallpike position, the canal becomes vertical and there is a ampulofugal movement of the otoconal debris, and the ampulofugal movement in the vertical canals is excitatory. The excitatory projections of the anterior semicircular canal are to the ipsilateral superior rectus, in this case the left superior rectus here that we see here, and right inferior oblique. Again, left anterior ampullary nerve excitation due to ampulofugal movement here, as we see, would lead to a slow phase which is upwards and right torsional. So in any case, it would be a fast phase would be downbeating and right torsional, whether it is right sided posterior semicircular canal BPPV due to the otoconia in the non-ampullary portion near the cross commune, or which is the other on the contralateral anterior semicircular canal BPP, where the otoconal debris is in its ampullary portion. This figure is from this article by Berthelon, in which they have drawn the position orientation of the canals in the right Dix Hallpike position by averaging the several figures which they have obtained from the books of anatomy and doing a MATLAB analysis, which is a software technology, and they found the orientation of the canals in vertical position on the right Dix Hallpike position like this. So this was the reason why we treated the patient with anterior semicircular canal BPPV. And this is an important diagram in the upper panel. This is from the Braunstein, and this diagram can also be seen in the David Z's book of Neurology of Eye Movements. The upper panel shows the excitatory projections of the anterior, posterior, and semicircular canals from the patient's right ear, and the lower panel shows the inhibitory projections from the right ear of the anterior, posterior, and horizontal semicircular canals. If we rotate this figure like this, now this is left ear, the excitatory projections of left ear from the left anterior semicircular canal and the inhibitory projections of the posterior semicircular canal from the right ear, they project to left superior rectus and right inferior oblique. That was the cause of the similar nystagmus pattern which we had discussed in the previous case. This diagram is very important to remember for every doctor or vestibular physician who is treating with patients with positional vertigo, because such surprises they occur. Fortunately, this surprise was very meaningful for us. We published this as the first case reported from India of apogeotropic variant of the posterior semicircular canal BPPV. Before this, only hardly 150 patients were reported, and I had a lot of guidance from Sudhir and Dr. Anirvar Biswas of Calcutta about writing this article. However, there are subtle differences. Just focus on the left diagram, left figure. You see this in this video. In the left Dix Hallpike position, there is, after latency, there is a buildup of nystagmus. See its right ear vessels. It slowly attains a peak velocity, and then it will start slowing down. This video is around 10 years old. Now it is slowing down. So this is a typical crescendo decrescendo type of nystagmus, which is right torsional downbeating nystagmus in left disc sulpike positioning, and this is diagnostic of right-sided anterior semicircular canal BPPV. We treated this patient with deep head hanging maneuver that time, and he was symptom free after 3 or 4 maneuvers. While the right side, you see that patient which we initially treated as left anterior semicircular canal BPPV and discussed in 3 or 4 slides, you see that the nystagmus is not classically crescendo decrescendo. It is downbeating, it is left torsional, but the intensity did not increase in a crescendo or decrescendo fashion, and this pattern of the nystagmus is called simul-paroxysmal downbeating nystagmus, and this has been described very beautifully by Vanucci et al., which had written a nice treatise on apogeotropic posterior semicircular canal BPPV, some clinical and therapeutic consideration in audiology research. So this article is very useful to read about the apogeotropic or atypical variant of the posterior semicircular canal BPPV. So in anterior semicircular canal BPPV, you see a nystagmus which is paroxysmal, and in the apogeotropic variant, it is simul-paroxysmal. Some of the Italian otoneurology linguist groups who are working in positional vertigo are able to identify this pattern at the outside. Otherwise, the usual story is that you treat such patients with contralateral anterior semicircular canal BPPV, you do some maneuver for them, and after some time they return with the opposite side posterior semicircular canal BPPV of the typical variant type. With this is another patient in whom we did a side lying test because he refused for head hanging as a diagnostic maneuver, and just see his right ear vessels. You see a downbeating nystagmus which is left torsional from the patient's perspective. Always see the vessels in the patient's eye to know the direction of nystagmus in different planes. So this indicated left-sided anterior semicircular canal BPPV. We treated this patient with deep head hanging maneuver, which is also known as the Iacoviano maneuver, from long sitting on the examination table. Patient's head is taken more than 30 degrees below the horizon, and it is kept in this position for full 1 minute. Then the head is taken in chin to chest position so that the vertex of the head is at right angles to the ceiling of the examination chamber. This is the second position, which is maintained for another 1 minute, after which the patient is uprighted to long sitting on the examination table, and he remains in this sitting position for another 1 minute, completing the 1 Iacoviano maneuver. Because there are no clear-cut recommendations about the anterior semicircular canal BPPV in any of the studies, in our clinic, it's a usual practice to do 3 to 5 Iacoviano maneuvers and to do a positional test after 1 hour and 24 hours. Side lying test was repeated. No nystagmus is seen. He was an interesting patient who refused for his head to be taken below the horizon while testing, but he agreed to it when I said that this means treatment for you. So no nystagmus is seen. We kept this patient in this position for full 1 minute because earlier we had a 1 minute nystagmus during positioning. With this, we come to horizontal semicircular canal BPPV. BPPV of the horizontal semicircular canals was first identified by McLeod in 1985. Its incidence in last 2 decades has ranged from 9 to 44%. The vertigo in horizontal canal BPPV is most severe, particularly on lying supine or in the lateral recumbent positions. It has a short latency of 2 to 3 seconds, after which a positional nystagmus, which is direction changing, geotropic or apogeotropic, it is attributed to free floating otoconia either in the posterior or anterior arm of the horizontal semicircular canal, which is called canalolithiasis, or otoconia becoming adherent to the cupula, which is called cupulolithiasis, which is designated cup C or cup U, depending on the side to which the otoconal debris is adherent. The horizontal semicircular canal BPPV is evaluated by Paganini-MacLeod maneuver, which is called the supine roll test. It elicits a horizontal bidirectional nystagmus, which may be geotropic, where the quick component of the nystagmus is beating towards the lowermost air, that is towards the earth, and or else it may be apogeotropic, where the quick component of the elicited horizontal nystagmus is beating away from the lowermost air, that is away from the earth. But one thing important to note in horizontal canal BPPV is that the supine roll test elicits, number 1, positional nystagmus on lateral head roll to right as well as to the left, and the pattern of the nystagmus has to be identical on the 2 sides. That is, if it is geotropic on lateral head roll to left, it has to be geotropic on lateral head roll to right, and likewise this holds true also for the apogeotropic variant. So with this in background, this is a person, this is an animation of supine roll test with lateral head roll to right, and I will show you how the geotropic nystagmus looks like. In the right lateral head roll, this is quick component, this is slow. Again, I repeat it once: quick and slow. Quick towards the lowermost ear, the slow is away from the lowermost ear. So in the geotropic variant, the involved side is one with the stronger positioning nystagmus. This has to be learned with heart when we are dealing with horizontal canal BPPV. The stronger nystagmus in geotropic variant is this involved side, that is lateralization is done on the basis of this. The next slide is about the apogeotropic nystagmus. The apogeotropic nystagmus is shown animated here. The slow component this is the lateral head roll to the patient's right during the supine roll test. The slow component is towards the lowermost ear, and the quick component is away. I show it again. Slow component towards lowermost ear, quick again from the lowermost ear. Again I show it. Slow component towards the lowermost ear and quick away from the lowermost ear. So this is apogeotropic variant. Here the involved side is one with the weaker positioning nystagmus. You should remember this by heart. So with this in background, this is the evolved second law. This I have shown in one of my recent papers published. This is exemplified as the left-sided pathology, and these are the positions of the left-sided horizontal semicircular canal, here B and C. Here I am showing the otoconal debris, which is in the long posterior non-ampullary arm of the left horizontal semicircular canal. As the patient is taken to the left lateral head roll, the otoconal debris, it shifts ampulopetal. While the patient is taken to the opposite side, that is right lateral recumbent, the movement of the otoconal debris is ampulofugal. and ampulopetal is more excitatory compared to ampulofugal in cases of horizontal semicircular canals. So left sided would be more stronger in cases of the in the geotropic variant, and the opposite holds true for the apogeotropic variant caused by anterior arm canalolithiasis or cupulolithiasis of the horizontal semicircular canal. With this anatomy in the background, we start the cases. This is the case one, a 17 to 18-year-old boy who had vertigo for around 3 to 4 days. Supine roll test in the neutral position, no nystagmus. To the right side, you see a geotropic nystagmus with the quick component beating towards the lowermost ear. So this is geotropic variant, and if it is geotropic on lateral head roll to right, it has to be the identical pattern on the left. To the left, you see again a geotropic and a stronger nystagmus. And as we had discussed earlier, that the side with the stronger nystagmus in the geotropic variant is the involved side, that is lateralization. So this was a patient with left long non-ampullary arm horizontal semicircular canalolithiasis. We treated this patient with Guffoni maneuver from short sitting on the examination table.
Ajay?
Yeah.
Ajay?
Yes, sir.
I will be leaving.
Okay, sir. Okay, sir. Thank you. Thank you, sir. To the short sitting, to the contralateral lateral recumbent position. Maintain in this position for around 1 to 2 minutes. 1 minute is enough. After which the head is inclined around 45 to 90 degrees downwards. 45 degrees is just enough. I did 90 degrees here. And this second position is maintained for around 2 minutes. After which patient is taken to the upright sitting position, completing one Guffoni maneuver. The usual practice in our center is to do 2 Guffoni maneuvers in one session of treatment, and we do a verifying supine roll test after 1 hour. Supine neutral position, no nystagmus. This has to be looked for lying down nystagmus, as we will see in few cases later on. Left lateral head roll, which elicited a very strong nystagmus 1 hour before, did not show any nystagmus. And so also the lateral head roll to right. Patient did not had any vertigo as well. The elimination of positional nystagmus during the verifying supine roll test or verifying positional test, as well as elimination of vertigo, these 2 things are mandatory to label this as successful treatment. We repeat the verifying supine roll test at 24 hours here also, but it is not shown here. What happened in this patient? In the panel A, we see the membranous labyrinth of this patient in the lower panel of left side. His membranous labyrinth of the left side. You see the otocondyl debris in the posterior arm of the left horizontal semicircular canal. As the patient is taken to the contralateral lateral recumbent position, right lateral recumbent position, the canal becomes vertical and the otocondyl debris, it shifts towards the non-ampullary utricular exit. As the head is inclined 45 degrees downwards in the yaw axis, the otocondyl debris goes inside the utricle, and on sitting again, that is short sitting again, the canal is cleared, and this brings about a cure. This is the mechanism how the Guffoni maneuver works. This is the case number 2, supine neutral position. You see a lying down nystagmus beating to the patient's right. This is a important secondary sign of lateralization. and you'll see how it helped. Right lateral head roll, 2 to 3 beats of geotropic nystagmus. He had history of positional vertigo for 4 days with vomiting. On left, again 3 to 4 beats of positional nystagmus. It is difficult to decide which was stronger. It was geotropic, but how to decide which was stronger? Because this patient had a lying down nystagmus beating to its right. So remember that lying down nystagmus in case of geotropic variant of the horizontal canal BPPV beats towards the opposite ear. So this is from our recent paper by me and Dr. Kothari. You see the fourth right panel, upper side. The otoconal debris is in the posterior arm of the left-sided horizontal semicircular canal. As the patient is taken to the supine neutral position, the otoconal debris, it shifts ampulofugal, that is away from the ampulla, and so does the cupular defects. It results in lying down nystagmus, which is beating towards the opposite contralateral right side. So we did a Guffoni maneuver again in the identical manner. From short sitting, patient was taken to the contralateral right lateral position for 1 minute, after which his head was rotated downwards in the yaw axis, and this was maintained for around 2 minutes, after which he was taken to the upright sitting position, completing 1 Guffoni maneuver. We did 2 Guffoni maneuvers in this patient, and 1 hour later we repeated a supine roll test. Supine neutral position, no lying down nystagmus, on lateral head roll to right as well as to left. No positional nystagmus was seen, and patient was free of vertigo as well. A repeat supine roll test was identical, no nystagmus and no vertigo at 24 hours. He was again followed up by telephonic interviews for 4 weeks, and he remained symptom-free. This is a article which we recently published on 4 July of this month only, in Hearing Balance and Communication by Taylor and Francis. And we observed that lying down nystagmus was present. We had seen 35 consecutive patients in around 45% of the patients of horizontal canal BPPV, 50% with geotropic variant, and 28.6% with apogeotropic variant. So this has to be always looked when you are doing a supine roll test. This is a case number 3, had a vertigo in left lateral recumbent position for past 2 days, only in the left lateral recumbent position. Dix-Hallpike test was not showing any nystagmus in left-sided head-hanging position as well as in the right-sided head-hanging position. And so also the supine roll test on lateral head roll to right as well as left was negative. So I asked him, did you had vertigo this morning? He said, yes, very severe vertigo. I was about to fall as I got up from the bed. And last night, every time I used to turn left lateral recumbent, I had a severe vertigo. So what I did was that I shook his head in the left Dix-Hallpike position, suspecting to unwell the nystagmus of left posterior semicircular canal. This has been done by, in one case report from Israel. For 15 seconds, I shook his head like this. But again, this did not elicit any nystagmus. I was about to ask him to leave this examination chamber and come to my table. He insisted me that you repeat this test again after 1 minute. I agreed to that. And when I repeated the Dix-Hallpike test, I saw an apogeotropic horizontal nystagmus. So now it was clear that this patient is having a horizontal canal BPPV, and for horizontal canal BPPV, the ideal test, recommended test for positional testing is the supine roll test. Supine neutral position, no lying down nystagmus, that always I look for. To the left side, now to my surprise, no nystagmus. I was perplexed what has happened to this patient. To the right side, a geotropic nystagmus. Quick component beating towards the lowermost light right here. So if it is geotropic on right side, it has to be same on the left side also. And now this time it was a stronger geotropic nystagmus, and this was diagnosed as left long non-ampullary horizontal semicircular canalolithiasis of long posterior non-ampullary arm. So accordingly, he was treated with the Guffoni maneuver, again from short sitting to the right lateral recumbent, that is to his non-involved side for 1 minute, head down for 2 minutes. We repeated 2 Guffoni maneuvers in one session of the treatment, which is our practice. And then we called the patient after 24 hours, sorry, after 1 hour, supine neutral position, no nystagmus, lateral head roll to left, no nystagmus, lateral head roll to right, no nystagmus, and patient was vertigo free. He was called 24 hours later, but he did not turn up, and he was inquired on telephone. He was free of vertigo at that time, and again weekly for 4 weeks he was free of vertigo. This was a 2-patient series which we unveiled the positional nystagmus of horizontal semicircular canal by diagnostic head checking in the yaw plane. This is case number 4, a 27-year-old female, had vertigo for 7 days. In the supine neutral position, you see after 10 seconds a left beating lying down nystagmus. Lying down nystagmus is normally not sought by the otoneurologist world over. To the right, lateral head roll, a very strong apogeotropic nystagmus with quick component which is beating towards away from the lowermost ear, and if it has to be there, it has to be the same pattern on the left side also. But we did the left lateral head roll too early, so it is the same nystagmus which was elicited on the right side, which is looking like geotropic, but this cannot be. If it was apogeotropic on lateral head roll to right, it has to be the identical pattern on the left as well. So we repeated this again, and now after some time you can see an apogeotropic nystagmus with quick component beating away from the lowermost ear. Compared to the right side, this was a weaker nystagmus, and the weaker nystagmus in cases of the apogeotropic variant is the involved side. So this patient had left-sided short anterior ampullary arm horizontal semicircular canalolithiasis, and the cupulolithiasis was not thought because the positional nystagmus was of less than 1 minute duration, and for one more reason that we will see in next slide. From the short sitting, she was taken to the ipsilateral lateral recumbent position. This is Appiani maneuver. After around 1 minute, his head was inclined 45 degrees upwards, in the yaw axis, and this position was maintained for 2 minutes. After which she was taken to the upright sitting position, completing 1 Appiani maneuver. As I had told, we do 2 maneuvers, Appiani or Buffoni, for the horizontal canal BPPV. We did 2 Buffoni maneuvers and evaluated this patient after 1 hour for verifying supine roll test. So verifying supine roll test at this time elicits no lying down nystagmus. On lateral head roll to right, you see a very small geotropic nystagmus, hardly visible. So if it has to be geotropic on right side, it has to be geotropic on left side also. And it indeed was. Now a stronger geotropic, quick component beating towards the lowermost left ear. What happened in this patient, that this patient transformed to the geotropic variant. The otoconal debris, it shifts from short anterior ampullary arm to the long posterior non-ampullary arm of the left horizontal semicircular canal as a result of Appiani maneuver, which we did 2 times 1 hour back. So how this happens is that this is a patient with the otoconal debris in the anterior arm of his left horizontal semicircular canal, as is seen with this hero. As the patient is taken to the ipsilegional lateral recumbent position on left side, the canal becomes vertical and the otoconal debris moves towards its posterior end. As the head is turned upwards 45 degrees upwards, the otoconal debris moves towards the non-ampullary arm exit, to the utricular exit in the non-ampullary arm of the left horizontal semicircular canal. The result could be either that it enters the utricle and clears the horizontal semicircular canal, and this is known to occur that it directly resolves. But more often, which I have personally observed, is that the Appiani maneuver shifts this otoconal debris from anterior to the posterior arm of the horizontal semicircular canal. So this leads to transition from a apogeotropic variant to the geotropic variant, and which can be treated by the Buffoni maneuver, as we have seen in previous all patients. From short sitting, the patient is taken to the contralateral lateral recumbent position, head down 45 degrees for 2 minutes, and then uprighted. Again, 2 Buffoni maneuvers were done in this patient. This is how the Buffoni maneuver works. This slide has been shown in previous first case of that 17-year-old boy. We did a supine road test after 1 hour of the Buffoni maneuver. Supine neutral position, no nystagmus. Lateral head roll to left, no positional nystagmus. Lateral head roll to right, no positional nystagmus. Patient did not complain of vertigo as well. A repeat verifying supine roll test was done at 24 hours, which was also same, no nystagmus, no vertigo, and she was again telephonically inquired about her vertigo for 4 weeks at weekly interval, and she remained symptom free. This is case 5. Supine neutral position did not elicit any lying down nystagmus. On head roll to right, that is lateral head roll to right, elicited an apogeotropic nystagmus, and this was a quite long nystagmus, around 3 minutes. We'll scroll this at the interval of 1 minute. At 1 minute, still it is present. Again, we'll scroll it after 1 minute. It is still present. So it is still present. So on right lateral head roll, the nystagmus lasted almost 3 minutes. And if it is apogeotropic on lateral head roll to right, it has to be same. On the left side, again we see an apogeotropic nystagmus beating away from the lowermost left ear. So this is the nystagmus intensity was weaker on the left side compared to the right, and so this was the left-sided cupulolithiasis. We treated this patient with head shaking maneuver with the head anti-flashed around 30 degrees. The head is shaken side to side for around 30 seconds. And because you are doing a severe vestibular stimulation, you have to keep a bucket because these patients are liable to vomit during this time. We did 2 head checking maneuvers in this patient at an interval of 5 minutes. And we repeated a supine roll test after 1 hour. Supine neutral position. She neither had a nystagmus initially during the diagnostic supine roll test in the supine neutral position, and so also this time. On lateral head roll to right, eyes are absolutely static. The apogeotropic nystagmus which was seen is no more, and patient did not complain of vertigo in right lateral head roll positioning. To the left again, the eyes are completely static, no nystagmus, no vertigo. A supine roll test was repeated after 24 hours, and again this was negative, no nystagmus, no vertigo. The dramatic response to head shaking maneuver indicates that patient suffered from the cup U variant of the cupulolithiasis. So this is a patient in whom the head shaking maneuver is done, in whom the otoconal debris is adherent to the utricular side of the cupula, which we have shown diagrammatically here, schematic diagram only. So when we do the head shaking maneuver, the inertial forces, they disengage the otoconal debris from the utricular side of the cupula, and as it disengages, it immediately disperses into the utricle, and this brings about an immediate relief both objectively as well as subjectively in terms of vertigo and disappearance of the positional nystagmus as occurred in that case. Case number 6 is the one of the most difficult cases that I had seen of cupulolithiasis. This was a lady of 7 days positional nystagmus and positional vertigo. Head checking maneuver was done, apogeotropic nystagmus of more than 1 month duration. The verifying supine roll test was again apogeotropic. We did a left posterior superior meatal oscillations. The third supine roll test, which was verifying, was again apogeotropic. Then we tried a alternating 180-degree maneuver to disengage the otoconal debris from the suspected canal side. The fourth supine roll test was again apogeotropic. We did a forced prolonged positioning in the left lateral recumbent position for 1 hour. The fifth supine roll test was geotropic. We did a Guffoni maneuver. This patient responded, and the sixth supine roll test, no nystagmus. But This consumed my whole day in treating one patient, almost 7 hours. This is the first slide. I will not show all the slides to their full extent. You see a very strong lying down nystagmus, which is beating to the patient's left. So as we had said, that lying down nystagmus beats towards the ipsilateral side in the cases of apogeotropic nystagmus. And if we see an apogeotropic nystagmus during the lateral head roll, it has to be a left-sided problem. Now you see an apogeotropic nystagmus on lateral head roll to left, which is weaker to that which was seen compared to the right side. The right lateral head roll shows a stronger apogeotropic nystagmus. So the lateralization was to the left side, left-sided cupulolithiasis. This patient was treated with head shaking maneuver. In the COVID times, we do head checking from behind so that the mass doesn't come below the nostrils. It was done. She was a very sturdy lady, a retired A&M who had come down from 400 kilometers Ratlam. We repeated a supine roll test after 1 hour that elicited again a lying down nystagmus beating the patient's left. On lateral head roll to right, again apogeotropic nystagmus beating from the lowermost ear. On the left, the identical pattern was seen. We did a mastoid oscillations in the posterior superior to the meatus for around 30 seconds. This is one of the methods of disengaging the otoconal debris from the cupula. After 1 hour of post-mastoid oscillations, supine roll test was still apogeotropic on lateral head roll to right as well as to the left. So she did not respond to the mastoid oscillations also. This was one of the methods used around 27 years back by Daniel Luti of Italy, in which the head was quickly rotated 180 degrees from involved to the non-involved side. The left side was the involved side with left cupulolithiasis because of the weaker nystagmus, and we did it 5 to 7 times. Daniel Luti in his paper was able to convert the cupulolithiasis on canal side into the geotropic variant by this maneuver. So I tried this maneuver. Again, we repeated a supine roll test after 1 hour. At least lying down nystagmus is not seen this time, but the apogeotropic positional nystagmus, which is clearly seen here, beating away from the lowermost right ear, is again persistent. And so also on the left side, although it is weaker here, as is expected from the left cupulolithiasis. So what to do in this patient? I asked her to lie in the left lateral recumbent position for 1 hour in one of my EEG rooms under supervision. So we suspected that the otoconal debris is on the canal side of the cupula, and we had applied enough of the inertial forces in the form of head shaking maneuver, mastoid oscillations, 180 degree maneuver. Now that they might have loosened, and probably they will gravitate under the effect of gravity by the force prolonged positioning to the involved side. So this is the ampulla, this is the cupula, this is the otoconal debris, and if they were expected to disengage from here and come into the canal. And we repeated a supine roll test after 1 hour, you can see that there is lying down nystagmus. Now it is beating towards the right. So this was a happy change which we had seen. On lateral head roll to right, initial few beats of upbeating nystagmus, and now you can see that it is geotropic with quick component beating towards the lowermost right ear. So if it is geotropic on right side, it has to be geotropic on left lateral head roll as well. You can see a very strong geotropic nystagmus with the quick component beating towards the lowermost left ear. So with all these efforts done to disengage, this patient ultimately transformed to the geotropic variant. And the geotropic variant is more amenable to treatment either with barbecue roll or with the Guffoni maneuver, which is the maneuver I prefer in my clinic. From short sitting, she was taken to the contralateral, lateral recumbent position, head down again for 2 minutes and uprighted. Then 2 Guffoni maneuvers were done. Again, she waited for 1 hour outside my clinic, and then a verifying supine roll test was done by 2 Guffoni maneuvers. She came in the morning as first patient at around 10 a.m. and left my clinic at around 7 p.m. in the evening. No nystagmus, lying down nystagmus. Lateral head roll to left, absolutely static eyes. On lateral head roll to right, again absolutely static eyes. Patient did not complain of vertigo at this time, and she was called again next day. She remained there, stayed there in my city, and the supine roll test was negative, which I am not showing here. So with this experiences of apogeotropic positional nystagmus, we have proposed a algorithm, and this is in one of our accepted papers from our group. If you see, supine roll test elicits an apogeotropic positional nystagmus of less than 1 minute duration. Do multiple supine roll test or APNE maneuvers. Transform to geotropic variant. It means that transformation of short anterior arm to long posterior arm canalolithiasis of horizontal semicircular canal. You can treat with Guffoni, barbecue roll, or a maneuver called forced prolonged positioning. The other thing is that you get a positional nystagmus of more than 1 minute duration. You do supine roll test multiple times, still apogeotropic. This is highly suggestive of horizontal semicircular cupulolithiasis. Do a head shaking maneuver if there are no contraindications. It could resolve apogeotropic positional nystagmus, disappears on repeat supine roll test. It means QPU, horizontal semicircular cupulolithiasis. You transform the geotropic positional nystagmus on repeat supine roll test. This means that patient had a cup C cupulolithiasis, which can be treated with Guffoni, barbecue roll, or forced prolonged positioning. Still apogeotropic positional nystagmus. It is suggested that it could be either tightly adherent otoconia to the cupula, or there is an alternate diagnosis. It is important to note here that apogeotropic positional nystagmus has been very rarely reported from the acute infarction of the nodulus of the cerebellum. This was a paper in 2012 by one of the otoneurologists from Orient, possibly China or Korea. Or think of alternate diagnoses like CJD or anti-GAD syndrome. There are unconfirmed communications from Professor Daniel Gold, who had lectured on the previous Sunday about CJD causing an apogeotropic variant of the positional nystagmus during the supine roll test. And one of the South Indian neurologists in his talk, he said that he had seen this apogeotropic nystagmus during the in the anti-GAD syndrome. So if the apogeotropic nystagmus is persistent, you better get the patients evaluated thoroughly for paraneoplastic, for stroke, and many things depending on the clinical profile of the patient. Case number 7 is the last case. This is a 72-year-old patient. 7 days history of vertigo. You are seeing a lying down nystagmus which is beating to patient's left. So one thing is clear, that he has got a horizontal canal BPPV. I will show this full video because it is important and it is very hardly seen. I have not seen any video of such patients on the scientific literature. And on lateral head roll to see, right, you see in the left eye vessels, there is an upbeat nystagmus, and which is clearly to the patient's right. So supine roll test on right eliciting a upbeating right torsional nystagmus. This is suggestive of right posterior semicircular canal BPPV. The lateral head roll has to be done on both sides, whatever the case may be. So we repeat it on the left side, and you can see a geotropic nystagmus with quick component beating towards the left ear, lowermost ear. So if it is geotropic on left lateral head roll, the identical pattern should be seen on the other side also. And now this time a lateral head roll to right was repeated, and we could see a geotropic nystagmus with quick component beating towards the lowermost right ear, and this was stronger as compared to that seen on the left side. So this patient had a multi-canalicular BPPV, which is the rarest of all variants. It was spontaneous, non-traumatic. Usually these are traumatic, post-traumatic. And he had right posterior semicircular canal BPPV as well as right-sided horizontal canal BPPV due to long posterior arm canalolithiasis of the horizontal semicircular canal. Such patients sometimes do not respond to one type of maneuver. I did my favorite Guffoni maneuver in this patient, but he did not respond after 2 Guffoni maneuvers. So I did the barbecue roll maneuver. From short sitting, patient is taken to the ipsilateral lateral recumbent position. I prefer to treat the horizontal canal first because they cause severe symptoms, especially the vomiting, nausea, and perspiration. So in this position, it was maintained for around 30 seconds, after which he was taken to the supine position, where he remained for another 30 seconds. This is the position 2 of the barbecue roll maneuver. In the position 3, he is now left lateral recumbent, and this is maintained for around 30 seconds, after which the patient is positioned prone with the nose pointing towards the examination table at right angles to the examination table. And after that, he was rolled back to the right lateral recumbent and maintained here for 30 seconds, after which he was uprighted to short sitting position. Whenever we have to do barbecue roll maneuvers, which we rarely do, we do it 6 times as per the recommendations from few of the papers in the literature. So because this patient had severe vomiting during barbecue roll maneuvers as well as the positional testing, etc., we decided to treat the posterior canal BPPV. The very next day, he was called, and we did first a barbecue supine roll test to evaluate the effect of barbecue roll maneuver. And on lateral head roll to right, the lying down nystagmus has disappeared. Lateral head roll to right, you see the left eye vessels. You can see a very small upbeating nystagmus with very minimal torsional component to the right. This is the residual nystagmus of posterior canal BPPV, which was much clearly seen during the diagnostic initial supine roll test. On the left lateral head roll, no nystagmus was seen and no vertigo was seen. We treated this patient with Apple maneuver 3 times. He expressed inability to remain for another 1 day. We took his phone number and telephonically inquired. After doing 3 Apple maneuvers, he was symptom free. So the last 2 slides, the positional vertigo is not always so benign. You see a downbeat nystagmus without latency, 2 to 3 beats only. And this is called the straight head hanging maneuver. This is usually done for the anterior canal BPPV. We repeated this again and again, and the same pattern of nystagmus was seen. I repeat this here because it was very short lasting. Two to 3 beats of downbeating pure vertical nystagmus. This patient was imaged. And he had a giant arachnoid cyst of the posterior fossa, which was compressing the nodulus here and flocculonodular lobe here. The nodulus, which is responsible for the velocity storage, if it is lesion, it can lead to positional downbeat nystagmus, as it has got a velocity storage mechanisms, which was discussed by Daniel Gold in his previous lecture last Sunday. With this last 2 slides, select the correct patient for positional tests. First, look for spontaneous nystagmus in any patient complaining of dizziness triggered or made worse by the head movements relative to the gravity. Positional tests are for those who are suspected to have BPPV lacking spontaneous nystagmus, and not for the patients with acute vestibular syndrome who require hints plus instead. Identify the correct semicircular canal, that is localization, and side lateralization. Most repositioning maneuvers or physical therapies for treating BPPV require both lateralization and localization. Direction of torsional component is towards the involved side in cases of vertical canal BPPV, that is posterior and anterior semicircular canal BPPV. In the apogeotropic variant of the posterior semicircular canal BPPV, the torsional component is towards the contralateral side. In anterior semicircular canal BPPV, the Dix-Hallpike test may be positive unilaterally, either contralaterally or ipsilaterally, or bilaterally. Take away point 6. In horizontal canal BPPV, the supine roll test elicits horizontal direction changing positional nystagmus during lateral head roll to either sides. The side that elicits stronger positional nystagmus in the geotropic variant and the weaker positional nystagmus in the apogeotropic variant is the involved side. Rarely the elicited positional nystagmus of horizontal canal during the supine roll test is of equal symmetric strength during the lateral head roll to either side. In such cases, secondary signs of lateralization like lying down nystagmus are important to decide the side. Number of therapeutic repositioning maneuvers. Posterior semicircular canal, a total of 5 are effective in almost 100% of the patients. This is from a recommendation paper by Bhattacharya et al. In 2017. These are the recommendations of American Academy of Otolaryngology, Head, Neck and Surgery, published in 2017. Then they were scheduled to be published in October 2020. I don't know whether they have been published or not. In horizontal canal BPPV, the number of maneuvers have not been in the recommendation paper. A total of 2 Guffoni or Apani maneuvers are done in our center. This is what the masters do. J.S. Kim et al. From Korea and Mandala from Italy published papers in 2012 and 2013 about horizontal canal BPPV, and they were about the randomized controlled studies, and they did 2 Guffoni or Appiani maneuvers in their studies, and that's what we follow. The anterior semicircular canal BPPV not clearly is specified in most studies. My personal choice is 5 because it is 5 for posterior canal BPPV as per the Bhattacharya et al. For the paper published in 2017 recommendations. The canal switch occurs in around 6% of the cases treated with repositioning maneuver. And for this, a verifying positional test is essential at 1 hour and at 24 hours after the therapeutic maneuver or physical therapy done for treating the condition. Thank you very much. This is my Udaipur. I am highly thankful to Professor J.M.K. Murthy and Dr. Sudhir Kothari for their kindness and blessings to entrust me the responsibility of taking up this topic for the masterclass of BPPV. My special thanks are to my teacher, Professor A.A. Safi, Professor of Neurology, Udaipur, R&T Medical College, and Professor Emeritus, ex-principal R&T Medical College, Udaipur, and Professor Thomas Limpert, Berlin, Chief Physician at Department of Neurology, Berlin, for his suggestions and persevering encouragement in pursuing otoneurology. That completes my presentation. I am almost in time. I would request, in the absence of Professor Murthy sir, my senior colleague, Professor Madhusudanan sir, to take up as the role of Professor Murthy sir.
Dr. Ajay, that is a really fantastic talk which you have given. I learned many points from your talk. I think there may be a lot of questions in the chat box. I will go to the chat box if the questions are any. In fact, I don't see any questions, Dr. Ajay. We'll ask the audience if they have got any questions to ask you. The organizer, kindly please unmute whoever you want to ask questions. They can raise their hand and ask directly to Professor Ajay. Anyone would like to ask the questions?
So we have 2 questions in the chat box.
Yeah, please ask. I cannot see that. You can ask. All right. I can see that. I can see that. How much time to be taken for doing single epilium maneuver? How fast head position should be changed? Ajay, you can answer that question.
Yes. This is from Dr. Anandan. The epilium maneuver, normally the recommendations from the paper by Bhattacharya et al. Is that each position should be maintained for 30 to 40 seconds. This is the recommendation paper. That's what we say. The other group from the Italy by Professor Esprella Giacinto, he says that the nystagmus should not be allowed to die down when the nystagmus of the posterior semicircular canal, that is upbeating torsional, ipsitorsional nystagmus, is slowing down and is about, you change it to the second position, and then when the second time the nystagmus is about to die down, then you change to the third position. So that is, they are using the inertia of the otoconal debris, which is using to reposition back. So that is the recommendation which I usually follow. But when it comes to practice, I have seen that sometimes it is useful, but sometimes you have to maintain it for 1 minute. This is first part of the question. The second part is how fast they should be done. We see that the consistency of the endolymph is not like water. The consistency of endolymph is like oil. So I asked this question to Professor Thomas Brandt in 2005 in Sydney, Australia. When I attended his master class of neurotology. That was a great inspiring class by Professor Brandt. He said that all these, that was during the coffee break I asked him. So I asked him to do the, how with the force which we apply on the, during the apply maneuver or during the Dix-Hallpike test, he applied it on me. He did it empirically on me. He tried it as a sham maneuver on me. And with that thing, I realized that if the thing permits, the position should be changed rapidly, because you are generating a inertia by the rapid change in position. Again, in the initial papers, that completes the first question. Adding to this, again, during the some of the maneuvers which I have been doing for the horizontal canal BPPV, I am taking the patients very fast. The thing is that in some of the papers of initial 20 years back by the Esprella, Giacinto and Guffoni, they were doing it fast. But when 2 years back they came to Pune for the neurotology meet, they said that now the recommendations are that you do it very slowly. So whatever the thing allows, if the patient's head, and like when you are doing the positional maneuvers for a long time, you come to know as you hold the neck of the patient how supple it is, and you have to rule out that patient doesn't suffer from a condition like ankylosing spondylitis or from a position like suspected atlantoaxial dislocation or any other CVJ anomalies which makes his neck fragile. So this is the answer to the first question. The second question is that these are very difficult to understand, sir. Maybe we should be strong at physiology and anatomy of the semicircular canal and their connections with extraocular movements. Please try to make a series of lectures from basics to otoneurology, which is not taught even at DM neurology level. This is our request for a resident. This I leave to Professor Sudhir Kutari, because he has been involved in the teaching and the fine neurology, and there cannot be a better teacher than Professor Madhusudan sir than anyone else. So this is really the anatomy we need to know. It's not just a physiotherapy. Many people have been trying this all over the world, but we need to know their physiology, the physiology of the ocular movements, and what happened in the case with apogeotropic positional vertigo, which we for the first time reported from the India. I directly sent the videos after discussing with Sudhir to Professor Giacinto Esprella. He reviewed the videos on WhatsApp, and he was very kind enough and replied that Dr. Ajay, you have reported you have found out the first case of the apogeotropic nystagmus from your country, and you reported. So that was the inspiration. And my all publications on BPPV are accompanied by videos. There is not a single publication which is without videos of the patient. So all those who are interested in pursuing otoneurology should go through those papers, because they contain all these videos. Nowhere in the world you will find these videos in any of the publications. Another question is from Dr. Chandrasekhar Rawat. Sir, there are any role of neuroimaging in BPPV? No, neuroimaging has no role unless and until you have an anterior canal BPPV which is not responding to the repositioning maneuver. There is only one maneuver which is called Iacoviano maneuver, and it is better to image in anterior canal BPPV if you have a positional nystagmus. There was a paper which I mentioned, which was from Bertillon, which is a 2002 JNNP paper, in which they analyzed 50 cases of positional downbeat nystagmus, and they found significant number of central positional nystagmus.
May I add to that, Dr. Ajay?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
I think neuroimaging is also required in those apogeotropic type of horizontal canal BPPV which do not respond to your positioning manual.
Yeah, yes, sir. Yes, sir. That I remember in one of the meets in which you were there. I think Dr. Bobby from Cochin had reported a case with anti-GAD body. I think he has submitted that paper or not, in whom the apogeotropic nystagmus did not respond to positioning.
Yeah, I had a patient who had a same pattern, who had an infarct in the medulla. Yeah,
Yes,
same
yes,
apogector.
yes, yes.
So that is another indication I think we should can consider.
The other thing is her Chandrasekhar Rawat, how to differentiate vertigo due to BPVP versus cervical spondylosis. Dr. Chandrasekhar Rawat, see, cervical spondylosis doesn't cause true external vertigo by any means. This is very much clear in one of the papers from Timothy Heil in 2004, published in Continuum of the Neuro Otology, or Continuum, published from the American Academy of Neurology. So the cervical spondylosis never leads to true external vertigo. I think any more questions?
Now, I may also respond to what Dr. Murali Krishna said. In the best way, in fact, this is a really tough topic to learn BPPV. So what I learned was that I started learning anatomy first. Anatomy of the canals, orientation, and the plane in which it is acting, and how it is linked to the extraocular muscles. Because each canal drives the extraocular muscle in the same plane. Whereas anterior posterior canal is driving the superior and inferior rectus and oblique muscles. Then you learn about the orientation of the cupola and the direction of flow, the ambitopit and ambulofugal, how it is stimulated. Then it is and the connection with the extraocular muscles. From the superior canal is how it's connected to the upward moving extraocular muscles, like that. Then once you know the anatomy part of that, then it's easier to understand. Otherwise, however you learn, you tend to forget. That's what I thought. What do you think, Ajay? Am I correct?
You are very correct, sir. You are a very great teacher. I am talking to you in person for the first time, but I had learned a lot from you about you from Dr. Fizu Chaku, who happened to be my senior in PGI Chandigarh at the time when I just joined. He was passing out at the time. Although I am much elder to him, but I always respect him as my senior. Fizu, he used to take you in very high respect.
Thank you, Ajay.
There's few more questions. How much time to be taken during a single abdomen? This I have answered. Is there any risk of patients with rare coincidental vertebral stenosis or dissection? This is from Chandi Das. He's another my teacher, now based in Australia, I think. He used to write CP Das. Sir, yes, there are chances of vertebral artery dissection in applied maneuver, and for this reason the neck movements may be done slowly during the Dix-Hallpike positioning as well as during the applied maneuver. And I do agree with many people that they should be done as the Giacinto Asprella has said lately, that all these maneuvers should be done very slowly, and I do agree to it that they should be. This is a real risk of dissection in patients whose necks are manipulated very fast. The other question is, with high resolution MRI, we should be able to see the structures. What is your experience of 3 Tesla, 7 Tesla studies? I think this is from outside. We don't have 3 Tesla and 7 Tesla machines available, and none of the studies on BPPV, except one recently by Professor Anita Bhandari from Jaipur, they have been able to see the canals, their orientation, but the otoconal debris was not visualized in any of the studies in the MRI. So what we should be doing is to navigate the otoconal debris by seeing the oculomotor patterns of the nystagmus generated during the positional test. We should localize and lateralize rather than going into 7 Tesla or 3 Tesla MRIs for BPPV. That is my answer, first answer to Professor Partha Ray Liverpool. Any role of ultrasound to displace ear rocks or otoliths, also focused on ultrasound in treatment of otoconia like lithotripsy for renal stones? I don't have an answer to this. I saw your magic wand. The magic wand was used because there is a role of vibration. Basically, what we are doing by the head shaking and by the magic wand, that is the mastoid oscillation, is the same thing. We are creating inertial forces that loosen the otoconia from the cupula, and if they are loosened, they will lead to cure. If the cupulolithiasis of U variant is there, as happened in our first case, and in the second case it did not work, we did lot of maneuvers. Again, all maneuvers were to disengage or loosen the otoconia by generating the inertial forces by different methods. Head shaking first, then mastoid vibration second, then 180-degree method, which was first used by Professor Daniel Nuti, a senior otolaryngologist of Italy, Siena. In his paper, he had done this. So what we were doing, I don't think that I have come across any paper in which lithotripsy or ultrasound has been used to move the otoconia or break the ear rocks.
If there are any other questions, shall we close the session, Dr. Ajay?
I don't see any questions, sir. I think I have answered 5 questions so far.
Then I will ask the last question to you.
Yes, sir. Yes, sir. Yes, sir.
In your practice, when do you do Simon's maneuver and Van Dorp maneuver?
Sir, in earlier days when I started doing my teratology practice, I used to do a lot of Van Dorp maneuvers, because the pathophysiology is you are just dissolving the otoconial debris. This is particularly true about the posterior canal BPPV, because in the Van Dorp maneuver, we orient the head in such a manner that the endolymph within the semicircular canals is shaken like this. So I used to do a lot of, because such patients have a severe vomiting and nausea during that time. So I abandoned that, and now Van Dorp treatment is used only in patients who had persistent symptoms without a nystagmus. I just tell them to do it on routine basis. Yeah. After they may be having, after say 6 months, they might be having triple PD, or for sometimes they have a post BPPV syndrome. They feel that they are unstable, they are about to fall, which cannot be classified as triple PD. So that Van Dorp I do. Second question is that Simon's maneuver. Simon's is good, but see, I am a short fellow with a height of 5 feet 5 inches. And if a person who is 6 feet and much stronger than me, it is virtually difficult to take the patient on one side and then take him to the 180 degrees to the opposite side.
Agreed.
So I do a lot of exercise, but if the patient is a person who is 6 feet, it would be virtually difficult to do that maneuver for a person of my stature, who is very short statured and not very well built.
Because in my practice I do a lot of Simon's, because that does not require a coat without, sometimes the coat may be to adjoining the wall. So you cannot take the head hanging down. So I can do the Simon's maneuver in that position. And as you said correctly, the Van Dorp, those patients who combine a BPPV but don't have nystagmus, so that can do the maneuvers, I ask them, I teach them Van Dorp maneuver at home, and then do it, they come back. That's the thing I do. That's why I asked that question.
Sure.
So I think if there are no questions, I will close the session. And I once again thank profusely Dr. Ajay for excellent, really excellent talk. I learned many things from you. I look forward to your talk once again in near future. Dr. Ajay.
Well,
Thank you.
it's a matter of great pleasure, and it's a matter of great pride, a great salute to you that
No. It's
a person and a teacher of your caliber is giving me compliments like this.
no, it's not a compliment. It's what you deserve.
Okay, sir.